Hello, children of a lesser joint. Today's section is a continuation of the last segment, which was on severe onset debilitating headache. And of course, I told you the awful story about this 24-year-old male that we still don't have the answer to as to exactly what's going on related to the spot on the lung and the tumor he has in the brain. But there are other causes for sudden severe onset debilitating headaches, and one of them actually turns out to be a personal story. So I'll let you in a little bit on our personal life, and this pertains to my wife because in February of 2015 she developed a severe onset headache. And within a 3-day period, this became debilitating. The headache actually came on from the back of her head, which is called the occipital area, back here where the skull kind of, meets the neck. And then her pain progressed to the top of her head, called the vertex, right over here. And then from there, she started to get some of the dental phenomenon, where she got pain in the retromandibular area, right behind over here on both sides, and then it extended right over here to her carotid artery, and then all of a sudden she started to get stiffness in her jaw muscles, and she developed difficulty in chewing, pain in her teeth bilaterally, and this pain progressed and started to move around, and she developed some hoarseness and some persistent dry throat, and a sore throat, and then she developed some night sweats. Then she started to develop some scalp tenderness, which are some of the classic symptoms of what I'm going to get to and what the diagnosis was. Now, this occurred over a 3-day period that this pain escalated, and as I hit the 3rd day, I said, my honey's in trouble. So I made 3 phone calls. Phone call number 1 was to our friend who's primary care physician, and I got her in there, and we ran a C-reactive protein and a Sed Rate, and that came back the next morning, and that was significantly elevated at over 65 each. So I knew for sure something was up, and my preliminary diagnosis was that my wife had the symptoms of an arteritis. Some of you know it as temporal arteritis, but it doesn't actually have to occur in the temporal arteries. It can actually occur almost anywhere on the body. And the next phone call I made was to our neurologist that we've used for years, and I wanted to get the nasty stuff off of the table. And so we ran there, and he took a look, and they did some imaging studies, which of course thankfully turned out to be negative, and he put her on Neurontin. And I said to my wife, honey, you're not taking that Neurontin. That's not the right diagnosis. But I had a backup appointment with the rheumatologist, my friend Gary, and Gary takes one look at her. By this time, we had a second blood study done where I got another C-reactive protein and a sedimentation rate, and that on both of them were over 100. And my wife looks at Gary and says, my husband didn't want me to take that medication. Gary says, your husband was right. Well, that made me feel good, and Gary knew because I had spoken to him on the phone. I said, Gary, this is your case. I'm not getting involved with that. And he said, well, you shouldn't. So Gary took care of this. He then put my wife on high-dose prednisone, and her symptoms abated within a 24 to 48 hour period. They were all gone. On second testing, her Sed Rate went down to normal. I think the first Sed Rate that she got was at 7 after she had been up over 106. So this is what you end up thinking about, especially in a patient community that is 60 or over. Actually, the number is 55. However, what I want to bring to your attention is this. Because my wife had this disorder, and I saw within her symptoms, a lot of symptoms my patients come in with. Among the first presenting symptoms, as this thing started to evolve, was the pain in teeth. And I get patients like that, and they don't have any dental disease. And I started thinking, you know, I'm dealing sometimes with a younger community who have these symptoms. What are the demographics? What's the epidemiology of this disease? Because when you look at classic consensus symptoms, you tend to tie yourself into this area where you're constrained. And if your patient has symptoms like this, you're unable to move forward because they don't meet these consensus criteria. So as I started to look around in the literature, I found out that while it's not terribly common, there is a juvenile component of this. And as a result of that, I started to be able to add into my juvenile community. This is part of the differential diagnosis. Now, it's hard to get somebody to really back you on something like this, because where they're coming from is the consensus standard that the American College of Rheumatology has adopted. But you can't be shackled by something like that. Additionally, there was another body of literature which talked about the patient that doesn't have a high Sed rate or C-reactive protein. And these people can have classic symptoms of giant cell arteritis, or they can jump over towards the cousin of giant cell arteritis, which is polymyalgia rheumatica, and that affects the upper shoulder area, the neck, and the whole upper girdle. And when people go to get out of a chair, they have extreme fatigue, and they almost have to push real hard like this, like I'm doing, and lift themselves out of a chair. A lot of times it also affects the lower extremities. The course of treatment for this is high-dose prednisone, and for either disorder, you're on it for, give or take, approximately a year on either side of that. So it all depends on how your condition goes. But in telling you this story, I think it's important for you to be able to recognize that, number one, jaw claudication is a prominent feature of giant cell arteritis. It does affect the TM joint. If you don't have the typical standard markers that show up, there are other markers you can use. Anticardiolipin, which is a blood marker, is part of the antiphospholipid group, and that often is elevated in 20 to 25% of the patients. So you don't have to tie yourself when you have somebody that's unusual. And I think that if you go a step further, the arteritis is really considered a form of granulomatous disease as a vasculitis. And then you can see that when you go into the vasculitis group, how many diseases can actually affect the structures around the head and neck, especially the TM joint. And this has never really been considered a large part of the differential diagnosis here. So in analyzing a patient who has a new onset headache, or it has a certain chronicity to it because it flies a bit below the radar, you can start thinking about the vasculitides, and the high Sed rate and C-reactive protein do not necessarily have to limit themselves to a giant cell arteritis, because they're also found in other autoimmune and inflammatory diseases. So just as a way of helping you to expand on your armamentarium, at least the library part of your armamentarium, this is something that you can now include in your differential diagnosis. When you hit the right symptoms, some of the things that I've mentioned with a sudden new onset headache, which is probably the largest criteria, you can definitely think about this, particularly as a strong association with a community that's 55 years old or older. Thank you.